Thank you very much. Thank you, James and Charlie, for asking me, and thank you for your help in putting up the presentation. We'll continue where Russell Warren has wished for since 1985, and it's the all-inside technique. I have no disclosures. What we will see is that clinical evidence is still thin, especially long-term, so I will focus on biomechanics and especially on the technique. So if you look at the biomechanics, and if you look at the study that was published in the American Journal of Sports Medicine by one of the members of our committee also, is you see that in the middle of this, the vertical fast fix has the highest failure load, and it's the stiffer of all the constructs, which gives us at least a good support and time for the meniscus to heal. I think before we saw that if you look at outside in, and what Tim was telling is that the anterior horn is very well fitted for that, and I think we were looking for solutions for especially the posterior part, and the all inside can give that solution from the inside, staying clear of posterior structures and giving a good and stable fixation. So that's true for the posterior horn of the medial meniscus, and it's true of the posterior horn of the lateral meniscus, and you can extend that area into the middle portion of the meniscus as long as you don't have to work back into you. So the grey area in this slide is also a grey area where if you're working with your all-inside meniscal sutures, you can find good grip, and you can also use it there, or you can go to an inside-out suturing technique. I think we saw very nicely in Thomas's presentation that the anatomy is crucial, and you need to know, of course, what is not only intra-articular, but was also situated extra-articular. And if you look at this slide, you know that you're pushing this all-inside suture through, you're stopping it, you have a stop which makes sure that you only grasp the meniscal part and the capsular part, and that you don't push through, so you don't touch on the neurovascular structures, try to evade them, and you don't grab any of the other vital structures that you see posteriorly here. The only thing you need is you need to enhance the healing capacity. I think that was well established before. You can use RASP, use the 4 steps, the RASP, the Schaefer, the needling, and the microfracturing, and then you use the suitable suture that you need. The fast fix is a straight one, or you can have a curved one, and also you have a reversed one, and I will explain to that why you could use that one. It's helpful to use a slotted cannula because it helps passing the suture in, and it makes sure that you don't grip any of the soft tissue that is there, and it can also help placing exactly where you want your suture to go through the meniscus. The curved one is a curved one up, and there's also a curved one for the downside, because looking at where the bevel is to grab your meniscus, if you go from the underside of the meniscus, it's difficult with the normal one to catch it, and if the bevel is the other way, it's easier to catch it and to penetrate with the suture anchor. So you place the slotted cannula, you put the tip through, you push it through, and once it's through, you feel the resistance gone, you just click, and you see it attaches on the outside of the capsule, you retract, and you're ready to fire your second anchor. The clicking is important, so it's just one movement, and you make sure that it's back in its posterior position again, because in that way it loads the second anchor. If it's stuck halfway, you just pull it back and it will reload, and you're ready to fire again. So when you look in the knee, you've chosen the position, you've put the slotted cannula in, you've taken a position, preferably a vertical mattress gives the more support. You push it through, you take your second position, you push it through, you feel the resistance, you click, you pull out the device, you pull on the cord, and you see how it already puts the tension onto the anchor, and you've reduced the lesion. What you see here is that it's a little bit upwards, and if you think at about every 5 to 8 millimeters, it's wise to put another suture to give good fixation. So if it's up like this and you go down, you take the reversed, you push it down, and once you've unloaded the anchor by pushing it forward, you pull it down, and you already see when you're retracting that the meniscus is pulled in its place. You have a well-positioned meniscus ready to start healing. I would like to present you all the clinical outcome and long-term outcome. I think it's clear if we look at all the data that saving the meniscus is vital. I think we know that this is a very biomechanical, stable solution that we have, and if you watch out for possible complications, you'll do a great job. And I would like to end to say that the all-inside meniscal repair, I think it's the best thing since sliced bread. Thank you very much.